This is case CCTA number 19. The history is that of a 58-year-old man who has an abnormal stress test suggesting posterior or inferior wall ischemia. There are 3 phases for review. These can be changed by changing the cine control in the next or previous button. Let's concentrate on the area of the right coronary artery. Let's get this in the middle, and then on a 5mm MIP, attempt to navigate around the right coronary artery. We proceed around. It's quite clear that there is clearly a lesion involving the proximal mid portion of the right coronary artery. If we rotate around this lesion, you can see that it probably is not calcified. There may be some ulcerated area, but there's clearly non-calcified, eccentric, and obstructive disease. Let's just change to a different phase to be sure that we can confirm this in all phases. It looks like probably the second phase here is probably the best review. That's where you see some potential for some ulceration, but clearly focal obstructive disease. So the stress test is clearly a true positive. If we follow the remainder of the right coronary down, there are some mild luminal irregularities, but no major issues. Let's get down to the foot view, looking at the posterior descending. This appears to be quite normal. There is also a very small branch, sort of an accessory posterior descending that has some calcified plaque. If we put this in the middle and switch to an MPR, it's very difficult to tell whether or not that also is obstructive. Switching back to a 5mm MIP, there also is a question here in the posterior lateral branch of the right coronary artery, right about this area here. As we rotate around, it's difficult to determine whether or not this is focal obstructive disease or an imaging artifacts. We switch to a 5mm to an MPR, then you can see this area is just kind of borderline to equivocal for obstructive disease. Regardless, though, we found the major lesion in this particular patient, and we need to then proceed for further evaluation, including catheterization and probably intervention with stent placement. However, let's look at the rest of the vessel to get a better idea of what's going on with this patient. So let's get back up and look at the left main and the left anterior descending. Left main appears to be normal. Don't see no major issues here. There is some mild eccentric calcified plaque, clearly non-obstructive in the proximal LAD. However, when we get to the mid LAD, you can see there is much more mixed plaque, calcified and non-calcified plaque. Just the same, this appears to be, if we switch around to different phases, this appears to be non-obstructive at this particular juncture. Moving down a little bit lower, more distal, we can look at the rest of the vessel. There's a diagonal coming off here that has some eccentric plaque, but focus on this area of the distal LAD as we rotate around this area, change phases to be sure that there's no motion issues contributing to this. We're still struck with the idea that there's kind of a reduced opacification in this area, which could suggest clearly a focal obstructive lesion involving the distal portion of the left anterior descending. So there's much more disease here than just what might be expected from the stress test. If we look at the origin of the circumflex, we can see that this is a non-dominant vessel, but in particular there is an area right at the ostium of the left circumflex vessel, which looks very tight, possibly some ulcerated as well as non-calcified plaque. Let's blow this up a little bit better and put this a little bit more in the center. Change phase just to be sure that there's no real issues here. This clearly is a borderline, likely obstructive lesion involving non-calcified plaque at the ostium of the left circumflex. So clearly very important to look at the remainder of this. This patient has at least triple vessel coronary disease, even though the stress test demonstrated only the suggestion for single vessel disease.